House of Standing Committee on Health is studying how Canada can stop relying heavily on foreign countries, particularly India and China, for essential medicines. The idea, at least on paper, is straightforward. If supply chains break, if geopolitical tensions rise, or if another pandemic hits, Canada should have the ability to manufacture and supply drugs to its population in need. So, Parliament called in a series of witnesses: pharmaceutical executives, industry lobby groups, researchers, and policy experts. Many of them came with proposals on how to rebuild domestic production, how to speed up regulatory approvals, and how Ottawa should prioritize Canada's drug manufacturing. But during the committee, something else surfaced. The conversation shifted from factories and supply chains to something much more deeper: how pharmaceutical policy is actually shaped in Canada, how addiction policy evolved over the last decade, and whether conflicts of interest inside public institutions have influenced the direction this country took. One of the witnesses who raised those questions was Dr. Julian Summers. Dr. Julian Summers is a psychologist and distinguished full professor at Simon Fraser University. Dr. Summers, welcome.
It's great to be with you, Dan.
It's for those at home that don't know who you are. Do you mind giving me a little background to yourself?
Sure. So I started in addiction in the mid 1980s, and I had a mentor at Simon Fraser University, where I am now, named Bruce Alexander, and I was working at Riverview Hospital. And the two things that affected me then, I was fascinated by addiction immediately, thanks in large part to Bruce. And I continued on. I went to further school in the States and practicing in other countries. But the beginning of the journey for me was deinstitutionalization, which was what I was contributing to in the mid to late 80s. And how the way we managed that seemed at that time to have a really obvious impact on the prevalence of addiction in the population, because it was already clear in the 80s that one of the things that increased risk for addiction was something called psychosocial isolation, or the lack of basically integrating into a meaningful life. So that's basically been my work since then. And I led research on interventions that help people, especially people who have very severe addictions where they've been homeless for a number of years, where they have serious mental illnesses as well, where they've got, sometimes lengthy involvements with the criminal justice system, repeated hospitalizations, those kinds of things. And then how do people who have those experiences turn things around? And first of all, let me emphasize, people do, but it requires supports that essentially help them over that transition toward what I'm calling psychosocial integration. It's not my term, but it's a bit jargony. Basically, it means having connections to other people, hope for the future, a healthy identity, motivation, and a feeling of self-control. Self-control is one of the things that's really conspicuously missing when people are experiencing an addiction, a harmful addiction. So that was kind of my journey, and I would say, so far so good. Randomized trials showing that people who'd been homeless for 10 years could socially reintegrate, could greatly improve their individual health, separate themselves from further involvement in crime. Like big things that those services and pathways cost the same as services that result in much, much less effective outcomes for people and for communities. And right at the time that we in BC and in other places actually across North America were beginning to experience sort of this first wave of fentanyl-driven addiction, I thought, wow, this body of work is tailor-made for this crisis. And just at that point, another sort of vision came into the picture, which was not at all connected to what I and my colleagues had been pursuing, but instead was essentially pharma first. The first thing you do is replace so this is where we get into sort of the framing. It's not an addiction crisis, it's a toxic drug crisis. So it's not driven by things that are internal to our society, things that are fixable, things that are understandable in other people's lives. It's driven instead by some kind of a supply-oriented force. And the best we can do is replace the toxic supply with a safe supply. And that essentially drove a lot of our policy thinking and public thinking for about 8-10 years now. And we seem to be coming out the other end of it because governments in many places across Canada and elsewhere who've tried these policies have experienced no real success and have formally backed away from them. But as we're talking now in 2026, there still isn't an alternative policy suite that is being talked about as the preferred path forward. So we seem to be kind of in neutral at the moment. And hopefully that creates space for this kind of conversation and for many other people to get involved.
Why do you think that there is what's the hesitation to create a policy? Because we look at the safe supply that you mentioned that they brought in, and it was hydromorphone, and we look at Samuel Cooper had an article detailing when hydromorphone came in to deal with the safe supply, and they looked at the statistics of how it came out and was distributed, and in his article he detailed that hydromorphone wasn't strong enough to deal with the fentanyl, and that what people were doing is that they were taking the fentanyl, they would do just enough to pass their urine test, and then they would go out and redistribute it on the street. And what we found, and I thought this was a very interesting statistic, was that youth-related overdose deaths from 2021 was at, so I think it was like less than 1%. 2022 was 3%. And then from 2023, we see it jump to almost a quarter of the deaths of opioid or overdose deaths in youth was 25% from hydromorphone. So my question to you is why are we so hesitant to actually deal with the policy? Because I think me and you talked about this before we went live, was that I see this as two issues. I see that we talk about safe supply, we talk about the toxic drug crisis, but at the same point in time, we call the drug addiction as a disease, but there's actually two parts of that, because you have the habit forming behavior that's behind the disease, and then you have the disease, the addiction itself. So you have two different problems. So you can't treat the disease without dealing with the habit forming behaviors behind that. So let me ask you a question: is what do you think the reason for people being so hesitant behind creating policy, like effective policy?
Well, one part of it is ignorance of the field of addiction, just pure and simple. We don't teach history and the effective practices to prevent and help people overcome and recover from addictions, other than very, very superficially in any of our post-secondary institutions. I'm not aware of one that has a program that focuses on preparing practitioners or policymakers by providing them with a relatively thorough overview of how we got to this point. And there have been efforts along the way. For instance, the early methadone programs that kind of put methadone on the map. They were in the late 1950s, early 1960s. They emphasized that methadone was a very small component of what made them successful, and they were successful. The first one program was in Vancouver, the Narcotic Addiction Foundation, and another one, better known, was in New York, led by a couple, Vincent Dole and Marie Neiswander. And those started because all of a sudden prisons in North America were filled with people who had addictions, heroin addictions. So they started this program, and they emphasized, look, what made our program successful, and they claimed 95% success ending crime. 95% success ending crime. How did they do that? Well, they describe it in detail. They helped people to reintegrate into communities. They helped them reestablish work, meaningful connections with their families. They talked about resuming lives as citizens. Their patients were resuming lives as citizens. And by the time they were into their second year or so of support, methadone was out of the picture. It was a transitional aid. Come the war on drugs, come a few other things, in the late 60s and early 70s, especially war on drugs. And the White House committed to a 10 times increase in funding for narcotic addiction treatment, but all the money went to methadone dispensing. And so Dolan Neiswander and others wrote later in the 70s, hey, you guys missed the plot. It was never about methadone. It was always about the resources that we had that helped people to socially reintegrate and overcome their addictions by doing something that was intrinsically more meaningful to them and that they, in many cases, hadn't had the opportunity to pursue before. So, no one really knows this anymore. You go to medical school now, and I taught addiction in UBC's medical school, and people come out thinking methadone's the treatment for addiction. Well, methadone actually doesn't treat anything. Let's back up and think about addiction is diagnosed and separated from other mental illnesses on the basis of the experience of loss of control over a behavior that's harmful. Doesn't have to involve drugs. We diagnose gambling as an addiction. Same category, same criteria. So how in the world can prescribing somebody a drug, how likely is it that that's going to cause them to reestablish control over drug-using behavior? There's no literature on that, essentially. It happens once in a while. Ayahuasca, LSD, for some people who have other building blocks in place. This is key. You can't expect that kind of outcome for someone like the populations that I've been working with, homeless, involved with crime, et cetera. So, part of it is ignorance. Part of it is, in answer to your question, so many other pressing policy areas. And if someone comes forward and says, I've got a solution that is relatively quick, easy to understand, easy to say yes to, right? That's very tempting. And people believed, okay, well, they believed out and out lies. I can only assume on the basis of laziness. What kind of lies? Well, the lie that pharmaceuticals can treat addiction, the lie that prohibition of drugs is universally bad. Our own provincial health officer here in BC is on record saying, well, as we all know, alcohol problems were made much worse during alcohol prohibition. That is factually the opposite of what happened. Alcohol consumption and related problems were far lower during prohibition than the years afterwards. It took decades for rates of alcohol consumption and problems to match the pre-prohibition levels, but it wasn't because of prohibition. Prohibition itself came about because there were so many groups within society around the world. It was not only a North American phenomenon. There were so many groups of people, especially women, urging society's leaders to embrace important social projects. And remember, this is only in the States decades after Reconstruction. So there were vitally important social projects to get along with, and all the dudes drinking too much was getting in the way. So it's not only about prohibition, it's about having something more meaningful and better to do. And that's what we need. That's what every society needs to overcome addiction epidemics. That's what helped in China. China went from having one of the highest rates of recorded addictions any time in history to having essentially no opium addiction. And yes, Chairman Mao was brutal toward people trafficking and using drugs, but he also allowed everyone in China who wished to become part of this incredible cultural revolution that had been pent up following the opium wars for decades, and everyone could be part of something. So this is part of what we need in Canada. It doesn't have to be that grand, in my view. If we look at who's dying, you mentioned the youth stats. And here in BC, drug poisoning is the leading cause of preventable death among youth in recent years. That's just a shocking reality. 75% of those kids received care from the ministry responsible for children and family development, foster care. 75%. So we don't need to transform the landscape for all youth in order to take meaningful steps toward reducing risk. Focus on youth in foster care. across the country, most of the adults that we've lost are adults who are young, working age, and unemployed, and have been unemployed for some years. So let's focus on identifying people who are clearly, at sixes and sevens. They're not finding a way forward, and let's support them to obtain jobs that are attractive to them, and at the same time practice waking up and living each day without their addiction. Those things are achievable, but those slightly more complex interventions in comparison to handing out drugs just got crowded out of the marketplace.
I would think it would be an easy business case, especially to taxpayers, when you look at like a youth prevention, because at the same point in time, you look at like what happens to these foster kids, as you pointed out, and then they become addicted and then they become part of the system. How much police resources. I remember talking to a friend and he's like, I don't want to pay for addiction. I'm like, well, you're paying for it anyways. Like, and what he meant by I don't want to pay for addiction, what he's talking about is the people that are addicted to drugs and that we have to pay them in to get out of society. And I'm like, well, you are paying for those people. You're paying for the police. You're paying for the paramedic services. I watched a clip today and they're talking about the Olympic, or not the Olympics, they're talking about the World Cup coming in here, and they're talking about the downtown east side. It was a streamer from England, and he came down and take a look at it. And this one man said that he has overdosed over 600 times, and he's like, I have the record of the most overdose in Metro Vancouver. And I'm like, what does that cost? And I think it's just like, I look at this as a mechanical thing. I think it's such a tragedy that this man is addicted to drugs, but we also have to look at the mechanics of that. How much are we spending on this person's addiction based on what we're using for what is hospital resources? Forgive me if I'm forgetting what the overdose drug is called at this moment. It's called
Naloxone?
Yeah, it's exactly how much we're spending on that per day. Every time we have to send an ambulance out to service an addiction, and I think I read a statistic that it's 20 calls per day. So we're spending like millions of dollars per quarter on this system. And as going back to what you were saying, I see it as an easy business case to actually set up supports for the youth, especially anyone from 12 to 24, and having like a platform that actually enables these people to recover, to actually allow them to contribute to society. Because when they contribute, they're actually putting out their resources, they're actually having a meaningful life. I don't see any dignity in addiction. I don't see any dignity what's happening down at the downtown east side. I that's just my perspective of seeing what these people are like. I don't see any dignity in these people withdrawing from fentanyl, and they're bent over and they're physically hurting because they're needing a fix. I see no dignity in that. But I'm digressing a little bit. Back to your profile. I saw that you worked at Riverview Hospital, and you mentioned it at the committee a little bit. Would you like to talk a little bit about your experiences there?
Well, in the 80s when I started work in the field, there was already well underway a movement internationally to deinstitutionalize mental health services for people who had severe mental illnesses, including addictions. And the reason we were deinstitutionalizing was that there was an element of it was there was a backlash against sort of the institutional model. Anyone who saw One Flew Over the Cuckoo's Nest was kind of like, ooh, that's I hope I never have to go there. But more substantively, there was evidence showing that people with these symptoms and syndromes did better if they were supported in their home communities. And we now know that over time, most people who develop fairly severe symptoms are very likely to have those symptoms attenuate in severity over time. It may take many years, but if we can support them in their communities while that's taking place, the overall severity will be lesser, and the opportunities for re-engagement will be vastly greater if they've been there all along than if we move them away for 5, 10, 20 years and put them in an institution. It makes it very difficult for people to adjust if we do that. So we had good evidence. The catch is that, and we said this, and government said this in most places where it was happening, that we're closing the institution and building a system in communities, and it was referred to as a community-based recovery-oriented system. And unfortunately, in many places, we simply didn't do that. BC is a good example, but there are many others that didn't follow up. In about 2007, a Canadian Senate committee undertook in Canada, this is our last exhaustive analysis of addiction and mental health and where are we. It was led by Senator Michael Kirby. And the report concluded that we basically have not followed through on our commitments with deinstitutionalization. And the main advice throughout the entire document is all Canadian jurisdictions need to get busy urgently establishing a community-based recovery-oriented system. And some governments have over the ensuing years come around to that. We saw it probably most clearly early in Alberta, where Alberta said the Alberta model is a recovery-oriented system of care. It includes all of government, because we recognize that all of government has a role to play in prevention, and when people experience severe symptoms, social reintegration. So we need to, left hand and right hand across ministries need to be talking to each other. One of our recent papers in BC was on St. Paul's Hospital, looking at about 4,500 people who'd been admitted for addictions, other mental illnesses. They stayed on average a little bit over 3 weeks. And 1 in 5 were discharged to no fixed address. 1 in 5, right? Just this amazing policy disconnect. And no surprise, those people who were discharged to no fixed address were vastly more likely than others to be readmitted within the next month. So taking this approach introduces a little bit of friction into public services. They have to change. It has to be driven from the top, because there's only one person in provinces and territories, a premier, who can write mandate letters to Minister of Health, Minister responsible for housing, Minister responsible for jobs, and say, in the next year, you will all work together to do X, right? That can only be from one person. And Ontario has been moving further in this direction as well, with heart hubs and other statements that are clearly oriented toward doing a better job at promoting recovery. But we're in the early innings of that. And, the good news is we have an immense body of evidence. You were talking about cost earlier, and I wanted to interrupt, but I didn't, but I'll say it now. Your intuition is completely supported by evidence. In about 2006, we completed, my team, I led a team that completed a thorough costing of per person per year, people being homeless, addicted, and seriously mentally ill in British Columbia. And it was about $55,000. And this is while they're in decline, right? Nobody's getting better. I thought, I've been proven super naively optimistic repeatedly in my career. And I thought, okay, well, there are lots of conservatives around in this space in 2007, federally, here provincially. This is going to turn things around. Didn't make any difference whatsoever. So then we got the green light to do randomized controlled trials, which cost $35 million in Vancouver alone, comparing usual care, $55,000 per year, against alternatives, housing people all together and housing them in a recovery-oriented way where they get to choose their place, they're interspersed among other people. We found that all three cost the same, and that only the recovery-oriented condition resulted in major reductions in crime and medical emergencies. So we had those results by 2013, 2014, and I thought, oh, okay, now things are really going to change. Not a chance. Nothing changed. So, it's had to reach a real crisis proportion where, for the first time in my career, a very large segment of the population is now affected by our neglect, right? We have not just lots and lots of cases of addiction, we have the implications for first responders, for business owners and people working in businesses, for families and kids. The sidewalk didn't used to be like that. The playground didn't used to be like that. And now we you know this ongoing burden that's very difficult to quantify, but this burden of somehow becoming okay with stepping over people on the sidewalk, stepping around human feces, right? Like, we don't want to offend people, but this is like, people have a hard time processing this. We should, right? This is alarming information about our society, but it's had to reach that point before we have any real chance, unfortunately, of turning things around.
No, I absolutely agree with you. I think it was last summer, we were in Squamish and we were at the park there, and there was like 3 needles like in the park there, and I had my 2-year-old, and I'm like, well, we're not playing here. I'm sorry. I absolutely agree with you, and I think that when we look at we talk about barriers to service. I was reminded of my childhood. I was 16 when I was introduced to heroin and addiction. My peer group of about 8 friends, they were addicted to heroin, and some of them are 25 years later are still addicted to heroin. Some of them have recovered. Some of them have passed away. When we talk about, I think we talked about methadone. I think one of my peer group members, they died of methadone overdose. Maybe that had to do with improper use. He died in his sleep, unfortunately. He regurgitated what he had eaten that day and died in his sleep, unfortunately, and it's tragic. But back to what I'm saying is that it's interesting that we talk about outcomes, because these people actually had resources. They had a family there to take care of them, and I think I'm not sure if it was from your testimony, or we just previously talked about it, but people in foster care that don't have these resources, that don't have these families with them, there must be tremendous barriers for these people to get better. And it very surprises me that we don't have the system in place, because if you don't have these resources, if you don't have a family network, I can't imagine what that barrier is to get better. What are your thoughts on that?
It's particularly hard in places that have relatively new societies, relatively new social and cultural traditions. Like, we're talking in BC, and in some ways, and BC has always had, as long as we've been recording stats, when you look across Canada, BC has always had the largest per capita number of people with addictions. Always. The first major census was the mid 1950s, and we had about half of the country's total addict population, and a tiny proportion of the total population at that time. And one of the main ways to explain that is that we're all newcomers. Now, of course, I'm not talking about Indigenous people here. Indigenous people are caught up in this because of the mess that has been made of colonization, and essentially their traditions, the ones that they had, were rendered useless for many First Nations people. But for the rest of us living here, we don't even all cheer for the Canucks, right? Like, we're all over the place. So we don't go to church. We don't see each other in church, right? We don't sing the same songs. We don't like the same food. We kind of celebrate our diversity. That's cool. That's nice, right? But we need things that bring us together in order to kind of establish a feeling of shared meaning, a feeling of sort of communal belonging, rallying behind things, and we're least advantaged in that regard up and down the West Coast. It's still totally achievable, but it requires, we can't rest on the laurels of many generations or centuries of this is how we do things, right? We can't look back but we can look forward. And that's, I think, the great opportunity that we have, and eventually we'll come around to it. We're in a very strange space as we talk right now, where even things like land ownership and like our actual questions, right? Just amazing things. But in a way, I hope that similar to the way that more and more people being affected by addiction has created a very broad dialogue. I hope that some of those other things contribute to an even greater dialogue around where are we going as a people. And like it would make a big difference, I think, if we had everyone agreed for 10 minutes in BC, for instance, to say let's think about what we would like to leave for 5 generations out. What would that look like, right? Would we in fact be energy stewards? Or would we still be divided between pro-pipeline, anti-pipeline, right? Would we actually be in some way energy stewards? Would we in some ways be thinking about our role as contributors to a global economy and international needs? And 5 generations out, I don't know what the answers would be, but if we can somehow orient ourselves towards tasks that really engage people, then we're on a path collectively to success. We don't have to do that to get out of this crisis, though. What we need are things like a concrete example is therapeutic communities. So there are therapeutic communities that have been created in many communities now in Alberta in the last 5 years. But one variant that we could use here would be communities co-designed with, let's say, the construction sector. What are the in-demand jobs in the sector for the next generation of employees, guaranteed in demand wherever you're going in BC, you're going to be employable. And so set those up. If you're struggling right now with homelessness, addiction, mental illness, the government will subsidize your going into a program like this, and you have to do 2 things. Go to training, earn your ticket over that period of time, and separate from your addiction while you're there. 2 things, that's it. And, a lot of places have had success with that. An interesting contrast is the way Portugal went about addressing their crisis. Again, Portugal was a society that could look back in order to establish, Catholicism and other things that very much underpin society. But one of the things that they did was install 63 therapeutic communities as part of their national strategy. And over the decade of their major turnaround, 0 consumption sites, no drug consumption sites. In BC, by contrast, after we declared our public health emergency in 2016, we installed no therapeutic communities and now 58 consumption sites as things deteriorated, just insanely. So we have to have the courage to rethink. And one of the things that's kind of stood in the way, unfortunately, is that people in positions of power not only were apparently engaged in self-dealing in terms of how we're going to get out of this crisis, but they actually took steps to obstruct transparency on what they were doing. It was a leak, a Ministry of Health leak, that really set the sort of the apple cart, off its axis. Not any ongoing monitoring. At the time the memo was leaked about pharmaceutical diversion and other kinds of graft connected to provincial programs, the politicians and other officials were declaring to the press that it's all going great. So, this is just a very alarming corruption of institutions that are meant to safeguard the public's interest, that clearly were not doing that.
I'm glad you brought that up, because that transitions to my next topic, which is the Standing Committee of Health, where I got to see your testimony on pharmaceutical sovereignty, and we had academics there, various lobby groups who were paid and they wanted the new slice of pie, and then we had you. And I'm glad we got to that part, because that was, for me, it was quite revealing. How did you? Let's start with how the genesis of that you got contacted for the pharmaceutical sovereignty study. How are you contacted about that?
I'd been asked previously. I mean, I'd been invited as a witness before, under this era of government, under health committees that are focusing on drugs and addiction. So I think that I don't know the reasoning for why I'd be invited to any of these committees. Here in BC, I've never been invited once. So we've had lots of committees, similar types of committees at the provincial level on addiction, and I think I've done more research on addiction and addiction recovery than anyone else I know, like in this region. I've never been invited once to a provincial committee, but I've been invited to variants in Ottawa now a few times. And initially, I wasn't sure why. Like, I had to look up pharmaceutical sovereignty. Like, what is that? And but once I realized that this is about both our autonomy, but it's also about protection from outside influences or corrupting influences, sovereignty, right? This concept of sovereignty. Then I realized, okay, I do have something to contribute on that regard, because we have been misdirected in terms of pharmaceutical policies by inappropriate reasons and insufficient safeguards that relate to things like profit and personal gain.
Dr. Julian, I'm sorry, I have to stop the recording for just a minute. I just had some technical issues. This will be like 5